the next talk. That would be me. Again, my name is Mark Gimbel. I am a surgical oncologist, and I am the medical director of the T.W. Lewis Melanoma Center of Excellence, as well as head of our melanoma multidisciplinary program. And I do again want to thank you for being here. So my talk is going to build on what Mary has started with, so we can get that going here. So Mary has identified this spot as melanoma. Now you get sent to me. You have melanoma. What are we going to do now? And this is one of the more stressful times I would say that patients experience, because they are just given a cancer diagnosis. And if you do any research on the internet with melanoma, there's really nothing good about it on there. So patients come to see me quite scared and fearful, but I'm able to put them at ease based on how we're managing melanoma and what melanoma has really turned into in the current landscape of treatment. I do have some disclosures. These are them. So the management of melanoma is based on the stage of the tumor. The tumor, I'm going to give you a little rundown of what the staging is. So a stage 1 tumor is a small, thin tumor, which you can see on the left side of the screen. A stage tumor is a thicker tumor, but still just on the skin. A stage 3 tumor is any tumor that has spread to the lymph nodes, and the lymph nodes are the draining nodes of that part of the skin. And then stage 4 is anything that has spread beyond the lymph nodes to the brain, to the liver, or even to the other parts of the body, the skin and the like. So we manage melanoma based on the stage, but the stage is based on the depth of the tumor into the skin. And the deeper the melanoma grows into the skin, the increased risk there is for spread. All the stem cells for the skin are in the epidermis, and these cells take the beating from the radiation from the sun throughout your life, and then they can start to mutate. And as they start to mutate, they form these skin cancers. But if the melanoma cells mutate, if these melanoma cells are only in the epidermis and have not gotten into the deeper layers, this is called a melanoma in situ, and there is zero risk of spread. But as it breaks down into the dermis and gets deeper to where the lymphatics are and the blood vessels are, the risk of spread increases, and that's how we determine what the stage is. So a stage 0 melanoma is called a melanoma in situ, and by definition, there is zero risk of spread. Now, we always want to remove them to make sure there's no deeper invasion in that biopsy or in that area where the melanoma in situ was. A stage 1 melanoma, I've kind of written a few things on here, but it's essentially any melanoma that's invaded beyond a melanoma in situ to 2 millimeters into the skin. And a stage 2 melanoma is anything deeper than 2 millimeters. Now, it's not uncommon for a patient to come to me and say, just panic that they have stage 4 melanoma. I can't tell you how many times this happens. Their dermatologist told them they have stage 4 melanoma. They need to get to a cancer center. You can't tell that just from a biopsy staging. Staging is a more in-depth workup, but what usually that means is that the patient has a T4 melanoma. And a T4, when we look at staging, we classify it as T, which is tumor thickness, N, which is lymph nodes, and M, which is metastasis if it's spread. You can't tell the N and the M from a pathology report, so it's just the T, and we're talking about the thickness of the tumor. So if a dermatologist does tell you that you have stage 4 melanoma, you need to take a step back and realize this is most likely just the T stage. We know that the risk of spread increases as the depth increases. Now, anything that has a less than 5% risk of spread, we're not going to start looking for cancer elsewhere just because the likelihood of finding something is quite small. But as a medical community, we've deemed that 5% and a higher risk is appropriate to start doing other studies or other tests to look for spread. Now, we don't do CAT scans. We don't do PET scans for someone who comes in with a melanoma that's 2 millimeters, 3 millimeters, because it's unlikely we're going to see anything on the scans, because scans don't show microscopic disease. And what we're looking for is that microscopic disease where it has spread. And the way we do that is by performing what's called a sentinel lymph node biopsy. So melanoma, if it spreads, it typically spreads through the skin lymphatics, which are fluid channels that run all throughout your skin and drain back to lymph nodes. And again, we're looking for these microscopic disease in the lymph nodes. And I need to assess when you come to me if you have that 5% or greater risk if the melanoma has spread to the lymph nodes. Well, there's three different parts, areas, essentially three different lymph node basins on the body where the melanoma is going to drain to. For the head and neck, the lymph nodes run along the jugular here. We call these the cervical lymph nodes. For the upper torso and the arms, the lymph nodes are in the armpit, and these are the same lymph nodes that breast cancer would travel to. And then for the lower torso and the legs, the lymph nodes are in the groin. Okay, so I would need to assess the draining lymph node based on the location on the body where the melanoma is. So let's just assume that you come to me or a patient comes to me and they have a melanoma, we'll just say on their forearm. Okay. Well, the most likely drainage, the lymphatic drainage in the lymph nodes are going to be in the armpit. Well, in your armpit, you could have anywhere from 20 to 40 lymph nodes. But if this melanoma is going to spread, and this is all if, it won't spread to all of them equally. It'll typically spread to one or two lymph nodes first. And we call those the sentinel lymph nodes because they're the sentinels are the guardians of the rest of the lymph nodes. So I don't need to assess all the lymph nodes. I just need to assess the sentinel lymph node to see if there's cancer in it. Well, now you might think if there's 20 to 40 lymph nodes in my armpit, how is Dr. Gimble going to find the right lymph node? They're all in there. I'm not going to feel anything. I'm not going to be able to see anything. So we actually perform a test before we go to the operating room to remove that melanoma. And that test is called a lymphoscintigraphy. So what does that mean? Again, I'm going to take the example on the arm. Then I'll talk about these pictures in a second. But when you come in or a patient comes in with a melanoma that's at least 0.8 millimeters or greater, so it has a higher than 5% risk of spreading, what we'll do is prior to going to the operating room, where that melanoma is, we will inject around that melanoma with a radioactive tracer. And that tracer will get taken up into the skin lymphatics and it will drain to the first draining lymph nodes. I guess if we look at square C here, the melanoma is on this patient's back. The radioactivity tracer was injected around here, and you can actually even make out this lymphatic draining to the sentinel lymph nodes. So these would be the lymph nodes I would need to assess. I would tell you that if the melanoma was here, it would drain to different lymph nodes. So each part of the body drains to different lymph nodes, and that's why we need to do this test to be able to localize it. Now on the arm, it's easy. The body's pretty lateral. It'll only go to one spot typically. But you can imagine if you look at the top left square here, having a melanoma right in the center of your body, right here or under your torso or under your sternum. Well, that drainage pattern could go both directions. And so I would need this information before we go to the operating room. So after we do the injection, we lay you under a camera and get these images so I can identify if there is more than one node basin where it could drain to. And again, just because the nodes are showing up here does not mean there's melanoma in the lymph nodes. It means if the melanoma is going to spread, these were the ones that it would be in. Microscopically, these are the ones I would need to sample. I've actually had a patient who had a melanoma right in the center of their torso, and it drained not only to both armpits, but also to both groins. Not the lymphatic strain. None of the lymph nodes had cancer in them, but we wouldn't know that until we remove them. So once we identify the draining lymph node, the sentinel lymph node, we then go to the operating room. And in the operating room, that's when we put you to sleep. And at that point, when you're asleep, I inject around your melanoma now with a blue dye. And that blue dye gets taken up into the same lymphatics and it will turn the lymph nodes blue. So I now have a visual cue when I'm operating. When I see a blue lymph node, I know that's the sentinel node. And then I also have a device called a neoprobe. A neoprobe is essentially a handheld Geiger counter where I can put it in my little wand, as you can see here in the second picture, and I can isolate where the radioactive lymph nodes are. I make a small incision about 2 centimeters, under an inch, and I'm able to go in and take those hot blue lymph nodes out. And then I send those lymph nodes to the pathologist. One of the frustrating things for patients is that I don't get any answers on the day of surgery. It has to go to the pathologist to have evaluation with special stains. And it takes a few days to get those results back. And I know those days are hard for the patient to wait to get the answer, but we need to make sure that we do the test appropriately because we don't want to miss something and we don't want to rush it. So that's how we would assess for spread. If there's no cancer in the lymph nodes, then all you have is the T part of the TNM, and you have a stage 1 or stage 2 melanoma based on the depth of the tumor. If there is cancer in the lymph nodes, and you have at least stage 3. So again, that's how we assess for spread. But not only when I go to the operating room do I assess your lymph nodes, we also need to do more surgery where that biopsy was done for the melanoma. And I perform what we call a wide local excision. Well, why do we do something wide? We know that while the melanoma has been biopsied, a lot of times there's some cells around that melanoma that can also be malignant, can regrow if we don't do a wider excision. The studies have shown that if we just do a narrow excision, if we just biopsy or cut it out, then there's a much higher risk that the melanoma will recur. And that's why we typically don't recommend Mohs surgery for melanoma, because we need to get that swath of normal tissue around the melanoma. And the amount of tissue I take is based on how deep into the skin it grows, because while it can grow deep, it can also have lateral spread. So for any tumor that grows into the skin 1 millimeter or less, and we're talking really tiny amounts, I need to take a centimeter of normal tissue around this to make sure we clear the area. And as the tumor gets deeper into the skin, I need to go wider, where if it's greater than 2 millimeters, I need to do a 2 centimeter margin. And you can imagine someone with a 2 centimeter margin of tissue, just under an inch all the way around it, it's going to make a significant defect, something about the size of a silver dollar. And having a silver dollar anywhere on your body of skin removed, it's going to be a nice hole that we have to close. And circles don't close too well. So as you can see on this picture here, I actually do an ellipse. I mark out the area around the melanoma that I need to remove, and then I cut the skin in an elliptical fashion, and that way I can get it closed and with a nice straight line. That line, again, will be dependent on how long it is, on how deep that melanoma is. So for any melanoma where I do a 1 centimeter margin, it's about a 3-inch incision. And then for any melanoma that's a 2 centimeter margin, we're talking about a 5 to 6 inch incision. So it can be disfiguring. If melanomas are on cartilaginous parts of the body, like the nose or the ears, obviously we can't close that. And you can see how disfiguring a surgery like that could be, and even on the scalp where you have to rotate things around. So I will just push that we need to make sure you're protecting your nose, your ears, all your skin, but be very cautious when you're wearing hats. Baseball hats don't cover your ears, so you want to be wearing wide brim hats there. When I remove this, I can then send this to the pathologist as well, and they will look to see if there's any further cancer cells in here. Now, if there's cancer or melanoma, say on your hand or in an area that's a little more delicate, you can imagine I can't always do a linear closure. So sometimes we need to use skin flaps and skin grafts. Have a great plastic surgery team who has closed many defects for me for either moving tissue or skin around to be able to get good coverage and a good cosmetic outcome as well. So that is the extent of a wide local excision and a sentinel lymph node biopsy. Now, I wrote here that if cancer is in the lymph nodes, it's at least stage 3. Well, what does that mean? Well, if I identify cancer in your lymph nodes, you're stage 3, but I need to make sure you're not stage 4, that there's no further cancer in your body. We've only identified the lymph nodes. So at that point, I would now offer imaging, such as a PET scan or a CT scan, possibly even an MRI of your brain to make sure there's no cancer elsewhere. If there isn't cancer elsewhere, then we know you have stage 3. If there is cancer elsewhere, then you have stage 4. It's important to know that because the treatment changes based on the stage. So if we look at just stage 3, we know that the treatment that we would offer you depends on how much cancer actually is in that lymph node that I removed, in that sentinel lymph node. So if there's only microscopic disease, only a few cells in that lymph node, removing that lymph node could be curative. You may not need any further treatment. And there are a select few of patients who we don't offer any treatment for after this surgery, even though it has already spread. If there's macroscopic disease, meaning there's larger volume of disease in the lymph nodes, well, now we know there's a higher risk of recurrence, meaning it can come back. And we would offer a year of treatment to prevent that recurrence from happening. The patient presents to me with what's called a clinically positive node, and that means something that maybe I can feel when you initially come in, or when we do a scan, we can see another node. That's a little bit more severe in terms of the amount of cancer you have, and then we would offer a completion lymph node dissection. A completion lymph node dissection means I now take that other 20 to 40 lymph nodes that I left behind to make sure there's no cancer in those other lymph nodes. It's a much bigger surgery, and we have to have some discussions with the patients about the benefits of that. So why do it? Why take out all those other lymph nodes? And again, it is to verify that there's no other cancer in the lymph nodes. We do know that the more cancer that's in the sentinel lymph node, or even a clinically positive lymph node, as I discussed, there's going to be a higher risk of having cancer in the other lymph nodes. And we don't want to leave that cancer behind because it can recur, it can grow in the other lymph nodes, and it can spread. And the last thing we want to do is have someone move from a stage 3 into a stage 4. So once melanoma is in the lymph nodes, we no longer call it a localized phenomenon. So if it's just on my arm, that's a local process right here. But once it's gone through the lymphatics to the lymph nodes, it's gotten into your system, we say. So now we need to have systemic treatment, something that treats the system. And that's not, we don't use chemotherapy for melanoma. It's been a changing paradigm in terms of how we manage melanoma. We used to use chemotherapy historically, a drug called interferon and interleukin. These were medicines that had significant side effects and had minimal responses. But the landscape has changed. The medicines that we have now are working so much better. And Dr. Mahmood will be talking about that shortly, but we use therapies that are called immunotherapy and targeted therapy. And these are the systemic treatments. But if you do have tumor in another part of the body, and I do have to operate on you in these lymph nodes, and I'm going to be taking out all your lymph nodes, should we start that treatment right away? Once we know you have cancer in those other lymph nodes, should we start treating you even though there's still cancer in those other nodes? Or should we go to surgery and then treat you afterwards to try to clear everything first and then treat you after? If we treat you before surgery, that's called neoadjuvant treatment. And if we treat you after surgery, that's called adjuvant treatment, words that you may hear a lot. We believe at our institution that treating somebody before we go to the operating room is going to be beneficial. Well, why would it be beneficial? Well, you say, you're leaving cancer there. Can't it spread? Or how can you leave that in me as opposed to rushing me to the operating room? Well, a couple of reasons. If you have cancer in your lymph nodes that we can see and we treat you before, we can actually assess the response to the treatment to see if it's working. And some patients even get a complete response. And in a select group of patients, we may not even have to remove the rest of the lymph nodes, but that's a discussion to have with the medical oncologist. Furthermore, if the tumor doesn't respond to treatment, we now know that this may not be the appropriate treatment and we need to tailor it later on. So it allows us to see what the tumor is doing. Plus, if you can imagine that the cancer has gone from the primary site to the lymph nodes, well, perhaps there are cells circulating elsewhere around the body that we can't see on a microscopic level because scans don't show us microscopic disease. So there may be some benefit to getting treatment ahead of time to start treating that other disease that we can't see. We were going to open up a study at our institution looking at this question about treating before or after. This was through Bristol Myers, but they just informed us a couple days ago, after I've already made these slides, so that they are not going to be going forward with the study across the nation. They're pulling the study. So we are looking for other studies to look at this question of neoadjuvant before surgery versus adjuvant or after surgery, because we think it's a very important question that needs to be answered scientifically. While anecdotally, we see that our patients are doing great, we want to make sure that this is something that can be relayed to all patients and it's the right thing that we're doing. And ultimately, I do believe this is the correct way to treat patients, because not only do it for melanoma, but we do it for other cancers as well, such as rectal cancer, pancreatic cancer, stomach cancer. So it's a paradigm that is beneficial to the patients, we believe. So that's stage 3. And now we move into stage 4. And stage 4, again, will be covered by Dr. Mahmood, but now the tumor has spread throughout the body. So really, is there a role for surgery once the tumor is in multiple locations or has spread elsewhere? I would say yes, there is, but, and when I say but, I mean in a selected group of patients. If there's only a small volume of disease someplace else, well, if you do well with treatment and it hasn't spread elsewhere, there may be a benefit of going in and taking out that small volume disease to render you without any cancer. And we've even seen late cures in that setting for stage 4 disease where patients don't recur after that. So there can be a role for surgery at stage 4. Similarly, if you can imagine cancer spreading to other parts of the body, it can cause symptoms. If it goes to the intestines, it can cause a bowel obstruction. These tumors can bleed. They can be painful. So in selected patients, there may be a benefit for me removing the stage 4 cancer to be able to alleviate some of the symptoms. For those tumors that we can't remove, such as in the brain or the liver, we don't think it's necessary or we should remove because it's not beneficial to the patient, putting you through a big surgery for an undefined benefit, that we can offer radiation therapy as well. And our radiation oncologists work well with us in terms of managing melanomas, say in the brain, the lung, the liver, other areas as well. So we get to work with a whole team in managing these patients. And I think that's one of the keys of what we do. We manage melanoma in a multidisciplinary fashion. So it means we're getting a whole group of patients who, a whole group of physicians, experts who are going to help manage certain tumors. So if you have a challenging or difficult case, it's reviewed at our tumor board. And at our tumor board, you have a panel of medical oncologists, surgical oncologists. We have a radiologist going through your images. We review your pathology to make sure everything is what it's supposed to be. The radiation oncologists are there, and even the genetic counselor is there to see, is this something that we need to work up from a genetic standpoint? So essentially, if you see one of our physicians, you're seeing all of our physicians. And it's a really great model because now we can take you as a patient and individualize your treatment based on these discussions that we have as tumor board. And having individualized treatment plans is very important moving forward. Not only do we manage your cancer upfront, but then in a multidisciplinary center, we can also establish surveillance with being followed by either the medical oncologist or the surgical oncologist, the dermatologist, and we can move patients back and forth as needed. And your surveillance is going to depend on the initial stage of your tumor, the biology of your tumor. There's a test that we can use that can look at the biology of your tumor to see if it's an aggressive biology. Again, we have dermatology. Mary can follow for any new spots that show up. And even medical oncology for longer periods if the tumor has spread, and ultimately survivorship if you're beyond active management of your cancer. Again, we can individualize this as well. And then we also have the ability to offer clinical trials. Well, I said this one clinical trial wasn't going to be open. We have other clinical trials that are open, and we will be recruiting even more. So that's what's next. I hope this was informational for you and you got to understand really the start to finish of surgical management and how and what I do for when a patient comes to see me for melanoma. And I'll be happy to answer a question or two, Allison, if we have any.